And you know, Tony, we have a lot of trouble with this disease. I think one of our barriers to success is access to tissue. We don't have big biobanks of big biopsies that we can do this with. So what's the strategy for getting this molecular testing done and in your practice? And well, let me kind of, as a corollary to that, is there any role for circulating markers in this patient population?
So that's a great question. I think that tissue is always important. One of the limiting factors with circulating DNA with this disease is that it's a hit and miss. There's actually a lot of miss than a hit, unfortunately, unlike, say, colorectal cancer or other cancers where the tumor burden tends to be higher and that environment around the tumor is not as protective from releasing those cells out and breaking the DNA, et cetera. So there is a challenge.
So not yet on circulating marker?
So I think if you do not have tissue or access to tissue, you should consider circulating DNA.
Can you get BRCA on blood?
No. Well,
yes.
germline versus
Germline,
somatic.
yes.
No, germline, I'm sorry. Germline, yes, we agree on germline. Somatic, not quite yet.
But there is an issue in terms of assays reporting BRCA in tumor for the reasons that we discussed.
But it's not a reliable.
So
it's not a reliable
it's not
test.
always reliable. It's not always reported.
It's not a reliable test, and so I think that with this disease, you have to try everything possible to get adequate tissue.
And you need a bigger piece, right? I mean, EUS, they're getting better at getting us some tissue, but it's still not a core or something on that side.
They're getting better.
So I think this is a very important point to make, right? That there's been a transition in terms of how we approach acquisition of tissue in people with pancreas cancer. The older days, it was an FNA was sufficient. We made our diagnosis and move on. But now we really want this core biopsy, either from the metastatic side or from the primary tumor, to facilitate these next generation approaches in terms of learning. And I think that's a big message for our community colleagues in terms of recommendations to their surgeons, their interventional radiologists, or their gastroenterologists.
You know, it's easy for us to say, but I've got a patient right now who's trying to enroll in a trial, and it's required that he has tissue on a biopsy. And we're at biopsy number 3 right now, because every time they go, they are right in the tumor, and what they get is a lot of stroma. They don't get enough tumor cells to do molecular testing, and of course we're all frustrated with that. What about this stroma, Tony? I mean, what's going on there, and is this part of our problem fundamentally?
So it's both part of our problem and perhaps part of our solution at the same time. You know, the whole issue of the stroma and the microenvironment pancreas cancer has gone both ways. In fact, you know, we think about it both as a friend and a foe. As a friend, it essentially keeps those cancer cells from metastasizing, and also, you know, and somewhat protects the cancer from spreading. On the other hand, it's also a foe because it keeps the good macrophages out, keeps the bad macrophages in, keeps the NK cells, which are beneficial, out, keeps the Treg cells confined into it, so it creates an incredibly immunosuppressive environment. And we've had a hit and miss with targeting the stroma. You know, the whole story around the hedgehog inhibitors was very confusing, looked very promising, and then ended up being, in one study, detrimental, in the other study, non-beneficial. And going back to the basics, the realization was if you disrupt the stroma, you actually increase the risk of metastases. And we're seeing some of those signals, and we'll discuss later with that agent PEC-PH20. Again, you know, this is both a friend and a foe, and how we handle it more as a friend rather than a foe is likely to make a big difference in outcomes in this disease.
George, I was walking down the conference center yesterday with another GI oncologist friend of ours, and this person was really expressing how frustrated they were that all of these other cancers have got these driving mutations and these targets, and we in GI cancer are still sort of figuring out our chemo regimens. Do you share the same frustration? Do you see some light ahead in the genomic world?
Yeah, so just getting back to the stroma real quick, I don't think stroma is a friend. I think it's a foe. And I think we have to target the stroma. And if you look at the drugs that are now being approved, nab-paclitaxel and Naliri, and hopefully PEG-PH20, they do impact the stroma. in a meaningful way. So I think we have to go after it, and more.
I think what you're saying.
Is this like China trade, friend or foe? Is he
Yeah, I
thinking
mean,
more
more new metastases, or we don't see that in the trials. You would see that in failure. So we don't see people aren't coming off of drug because they're having new lesions. So we're not necessarily seeing that, but I think hitting stroma is important. In terms of the mutations, oh my goodness, we've got a lot of work to do, and I'm getting very frustrated with targeting single signal transduction pathways. I really think we have to hit it in a multiple TKI manner, or drugs like regorafenib, which hit multiple receptors at once. I think that's the way that we need to proceed. And look where we are. We're using chemotherapy. We're using multi-drug therapies that are having some impact. And we need to do a little more work in terms of the molecular aspects, because there's so many mutations that are potentially going to cause resistance and then need to be targeted. So
yeah, I think we are all jealous of the other gang. Yeah.
Yeah, but I would echo your thoughts, John, that we're not getting away from chemotherapy soon in pancreas cancer, much and all as we would like to think otherwise. Having said that, I think it's a platform for how some of these other agents may be developed in this disease, and we've lots of examples of trials, right? Building anti-stromal agents on chemotherapy, building immune agents on chemotherapy, and this may prove at least a path forward to debulking disease, and then perhaps a strategy for some of these less intense agents being used as a maintenance approach.
Yeah.